opportunity to present today our results of the Delphi surveys to you. And we had an academic vote, the three of us who is going to present, and I won the match. Good. Yeah, but this is work that was done together with my colleagues from FPR. So we forgot to mention also Martje Barbus from AbbVie and Renate Schulze-Rath from Bayer, and then it's Katharina and me from Charité. And I think we made a mistake with the accent here. Anyway, good. It's a great pleasure to present the results of the first Delphi surveys. Many of you have participated in defining core outcome sets. And today, this is our official end of that process. We have to have a consensus meeting that we finally agree as the Harmony community on the results of those Delphi surveys. And this is then also the go for us to finalize the manuscript, which is currently in preparation and which we then will share with you, probably not before Christmas anymore, but early next year. Just to remind you again, what is a core outcome set? We started with a large list of variables for each of the diseases, 70 to 80, and we had to condense that. And based on the understanding what a core outcome set should look like, and here we were in close collaboration when we developed these core outcome sets with Paula Williamson from the COMET initiative, who are experts in defining core outcome sets. So those are outcomes that definitely should be in all the studies because they're important to all stakeholder groups. But on the other hand, this of course does not exclude that not many other variables will be included in the respective studies. And to define a core, I mean, we all know the core is usually smaller than the large list. It has to be significantly smaller. So what the COMET initiative suggests to be a good core outcome set, that's between 6 and 15 variables per disease. Otherwise, they say, then it's not a core anymore. And why am I saying this? Because for almost all of them, we really hit the point. And this is what we are now going to share with you. And again, for the Delphi survey, that a variable makes it into the core outcome set, we first had to define the rules of the game, more or less, and this was done for all the individual surveys. For AML, we also had published the Delphi survey design in trials. And this was, again, what were the criteria for a variable to make it into the consensus outcome set or to be kicked out. And to make it in, the criterion was that more than 70% of all stakeholder groups ranked the outcome as critical. That was the upper ranking, a rank between 7 and 9. That was the highest category. We had 3 categories, low, intermediate, and high. And only less than 15% of the stakeholders said that variable is not important. On the other hand, consensus out, that means that an outcome is dropped from the list. This is given if more than 70% of the stakeholders did rank the outcome as not important, or less than 15% of the stakeholders ranked the outcome as critical important. And if no consensus was achieved, then of course, we have to discuss that. So with regard to the consensus in criteria, we will start with AML. I mean, this was also the first Delphi which we performed. This was also the pilot for our Delphis, like for the other projects. And here is the results for the consensus in. So this is in total 11 outcomes. So I had said between 6 and 15 would be an optimal core outcome set. So here we really hit the bull's eye, more or less. And those outcomes were from the different domains type of event. So that was overall survival, complete remission with MRD negativity, clinical relapse, progressive disease, and for the time to event, progression-free survival, event-free survival, and duration of leukemia-free survival, or duration of time to read and what store? I'm sorry. Oh no, the duration of response. Oh shoot, I need more coffee. And with regard to toxicity, severe adverse events, discontent of treatment, and with regard to the patient-reported outcomes, physical function was made it into the list. And on the other hand, criteria, just to give you a flavor of how variables or outcomes were kicked out. Those are examples now for outcomes that just didn't make the consensus in criteria. This is what just not consensus in relates to, and this is a selection. So that means that one of the stakeholder groups didn't rank it high enough, and for example, for type of event, the regulators kicked out CRI. For fatigue, the clinicians were the bad guys who thought it's not too important. And this is the reason why those variables were kicked out. But this is exactly what the Delphi survey is meant to be, because we have to condense the set to these 6 to 15 variables. And with 11, I think we have a good core outcome set defined for AML. So those are the ones then in total who were kicked out as one of the stakeholder groups didn't rank it high enough. And then I think now we already come to the Menti. This is what we then propose, to keep those 11 variables I had shown at the beginning as our core outcome set. And if we all agree that this is the way to go, then we can move forward and publish the data. And hopefully you will now all say yes. Or almost all. I mean, we can, yeah.
With another presentation, and then the next Menti will come. So.
Yeah, so the results look promising. Okay. While you continue voting, perhaps then we can move forward. And if we are quick, we also have some time for a short coffee break, right? Yeah. Good. No, that's fine. So with regard to the non-Hodgkin lymphoma, that's then also the results of the Delphi surveys. That's the proposal for the consensus meeting. So here are the criteria that made it into the core outcome set. It's a little less outcomes. So in total it were 8, but we are still where we want to be. Here, overall survival made it, progression-free survival, adverse event SRE, then cardiovascular toxicity, tolerability-related outcomes. Yeah, I realize it's good that we have the abbreviations at the end. And then for the more patient-reported outcomes, made it sensory neuropathy, pain, and dyspnea. And then on the other hand, of course, there were many that I mean, here we only listed the ones that just didn't make it because one of the stakeholder groups was under the 70% range. All the others, where all of us agreed to be kicked out, those we didn't list because the overall list was longer. And again, to be consistent with also how we want to write the manuscript, we again would say, if it wasn't important for one of the stakeholder groups, it really has to be kicked out. So again, the Menti would be to vote on the list of 8 core outcome sets, the core outcome set of 8 outcomes which I showed at the beginning. So here we still see the results for the AML. Now it's not refreshing.
Where are the outcome sets?
Thank you for paying attention.
Yep.
Ellen, can the people online vote?
Yes.
Yeah.
Yep.
And I'm double checking if they all saw the coding.
Are these the outcomes?
Okay. Also looks promising.
understand the process. You know, where are the outcome sets?
Oh, I
Because
show that we will do it 3 more times by the end. Okay, this is the outcome sets that make it. That is the proposal for the consensus core outcome set for myelodysplastic syndrome. So these are the outcomes that were rated by all stakeholder groups to be as important in over 70% of the participants. And in total, for MDS, it's now 12 outcomes. Again, it has to be between 6 and 15. And from the domain type of event, the 2 outcomes, overall survival and clinical relapse, made it. From the category time to event, progression-free survival, duration of response, time to AML, time to high-risk MDS made it, so 4 outcome variables. Then out of the category clinical parameters, blood transfusion dependence, transfusion independence made it into the list. They were, yeah, so why we have both of them, this is again, I mean, we can discuss that in the paper. This will be the yes, no. This was out of the final list that went into the Delphi. We, at the MDS meeting, somehow had agreed that both of these are important. There is slight differences which will be discussed in the paper. And then toxicity, severe adverse events, and then also, again, 3 patient-reported outcomes. So those 12 outcomes were ranked as important by over 70% of the participants in each stakeholder group, and therefore they fully fulfilled the consensus in criterion. On the other hand, those are again, this is again the selection who just didn't make it because only one of the stakeholder groups didn't fulfill the criterion, and all the ones where several stakeholder groups agreed that it's not important, those we do not show at all, and for those we also do not have to vote because they're clearly out. And this is again then the next voting then, that we agree that those 12 that were rated by all of us, by all stakeholder groups, as equally important to make it into the MDS.
Lars, can you give an estimate how big the stakeholder groups were? I can imagine that there are huge difference between the numbers of registrational authorities and the clinicians, and that would make really a difference, because I saw that, for example, for molecular MRD, it was rejected because only the registrational people rejected it. And are that 2 people or are that...
That depends on the Delphi. The numbers are often small. This is also what we will discuss then in the paper. The problem is that if we start to come up with, let's say for Delphi 1, we say that stakeholder group was so low that the 66.7%, and if you see here, there was only 3 regulators, and it was dropped out because only 1 out of the 2 didn't rate it as to be important enough to get in the core. We could discuss that, but then if we start with these exceptions, to sell the story then in a way that we also can publish it will become very difficult. We will discuss it critically, and I think the core outcome sets which we defined in Harmony, because of all the limitations we had with the different Delphis, there were some Delphi surveys where we had a very good participation of the patient advocates. There was other Delphis where it was very hard to mobilize the patient advocates. Same vice versa. There was diseases where almost or very few physicians participated, given the fact of how important the disease is and how many should be participating. So we will discuss that critically in the manuscript, but I think we set the rules, and I now would stick to the rule and would not have exemptions, but that's of course a valid point you made. Yeah.
Excuse me, Elizabeth would like to have the microphone, and I would like to, in the meantime, if you're okay with that, react from the chat, from the MDS Alliance. I'm very surprised that fatigue did not make it.
Yeah, as I had said, the problem here were the physicians, right? Because they rated or they thought that fatigue is, I mean, that doesn't mean that physicians think fatigue is not an important symptom patients have. So this is to be clearly, and in the future, we of course always should ask for fatigue if we think of AML patients. But in the Delphi survey, how we performed it, fatigue did not make the criterion for the doctors, and therefore it was thrown out. I mean, this is how the game is played, right? That we nail it down to a small list of variables that should always be there. Again, this does not mean that all the other variables that were falling out of a respective Delphi are not important or should not be included in clinical trials, right? Because many of the variables which we always look at did not make it in the core outcome set.
Yeah, Elisabeth.
I think this is very interesting. It's numerical democracy. And it depends how important the results are. Because listening to you, I'm trying to wonder what would have happened if Britain had done a core outcome series of parameters with all stakeholders agreeing on a Delphi process, and would Brexit still have happened?
Yeah.
That's without suggesting this to Boris Johnson, the end result. I think what Gert just said about. You do have a capacity for a certain amount of dominance, negative or positive. And so I'll be very interested to see how the reviewers evaluate the paper. And we should also remain pragmatic.
Yeah.
And remember that in some way you have to move forward.
Yeah.
And making participative democracy work is hard work.
That's true.
So well done on the initiative. But I don't know what the legislators will say about the consequences of when participative democracy maybe gets it slightly wrong.
Yeah.
Without going back to Brexit.
But that's exactly what we should put in the discussion. Not sure we should link it to the Brexit, but depends on the journal. Yeah.
Lars.
But it's a very good point. Yeah, I mean we have discussed that several times that it was hard to perform and also I think the COVID pandemic made it even harder because everyone was flooded with emails and then all these reminders. And then we could not, once we had the momentum, then there was some delays again. And anyway, so there at the end, if we have some time, I will also will suggest how we move forward in Harmony Plus, where we also have to do more Delphi surveys on the new treatments, and where we also said that based on the new developments, the new drugs, we are going to refine the core sets which we had generated in Harmony. So we will have additional opportunities, for example, to address also the point Gert was raising. Okay, then 2 more to go. For multiple myeloma, again, 12 outcomes made it in. CR, clinical relapse, progressive disease, overall survival, then PFS, PFS2, again, duration of response, molecular MRD, SRE, discontinuation of treatment, pain, and pathological fractures. On the other hand, it's nice to see that these disease-specific pros, which are usually like pathologic fracture, it's not so important in AML, but that those made it. And also with regard to the ones that just didn't make it, that list, I think I do not have to go over it. But again, to stick with the rules which we set at the beginning, those would be kicked out, would leave us with the 12 I mentioned, and again, that's where we wanted to land. And I think we have to refresh again. Oh, now we are with CLL. That's not correct. I showed MMM.
Yeah. Can you go back? MM should be in
multiple myeloma should be the mentee. Yeah. Or we can also do a combined vote on CLL.
No, we can go back.
No, but it's nice to have the votes then to
if it's
to
not
show
there,
them, include them in the paper as a supplement.
I think we miss it. Could you maybe copy paste, add a new slide? I think we miss MM. Yeah, can you maybe include it? Is it okay to proceed with CLL?
Yeah, we can proceed with CLL.
And then we do MM.
For CLL, 17 outcomes made it, so this is the largest core outcome set, if you wish. So there we are slightly going over the upper border, but I think this is fine. CR, stable disease, clinical relapse, progressive disease, overall survival out of the domain type of event, out of the domain time to event, progression-free survival, event-free survival, duration of response, time to progression, time to next treatment, time to transformation, and treatment-free interval. What you can see from here, I mean, with CLL, we are doing also really well over the last years and having these new treatments that almost cure many of the patients. And then, of course, toxicity is then playing a larger and larger role if you survive the treatment so long. And, of course, then also use of resources, as some of these, also can produce side effects. And then, of course, it's important whether this is happening more often or not. And with regard to the criteria that just didn't make it, those are listed here. But again, as we are there where we want to be, I would suggest to vote for this core outcome set of 7 outcomes for CLL. Whew. Getting more difficult to get a vote on a CLL. Seems to be a complicated disease. Just kidding. No.
Lars, maybe you can invite the online viewers to vote
participate as well.
Yes, because we have, for your indication, about 28 people in the room and 55 online.
Yeah.
I mean, there are issues about representativity. If there are only,
Also, yeah.
If there are only 20 votes for 80 people,
Mm-hmm.
Mm-hmm.
do you have a Delphi consensus on the percentage that have to vote?
Fortunately not. Yeah. No, there is no lower limit. Yeah.
Okay. Thank you.
But I mean, we have 5 who cannot decide, and 2, a clear, I think it's more or less a clear yes. Yeah. Anyway, let's move forward now for the myeloma. Sorry, I have to go back. Can we have the myeloma one? Yeah, okay. Again, to remind you, myeloma was these 12 outcome variables, including the patient-important ones, pathologic fracture. But this again also shows a little bit, I mean, at the early Delphis, the participation, or also the first round of Delphi, the participation is much higher. Then many drop out in the second round, which is also, of course, a problem with regard to the validity of results. But there we have some idea how we could approach that in the future. And then in the end, again, what we had a special category of variables where we said those should be mentioned specifically or will be discussed specifically in the paper, where mainly the patients rated them as very important, and they didn't make the consensus in criterion by any of the other stakeholder groups. And these are for the diseases. So this was only happening for non-Hodgkin lymphoma, myeloma, and CLL. And you can see the outcomes that were rated very, very important by our patient advocates or patient participants, but by none of the other stakeholder groups. And those, they will get a specific section in the paper and will be mentioned there and will also be then discussed. And for the discussion, we also then have come up with some ideas how they could be well captured in future trials and how that could be done with, let's say, not a large additional effort, as many of them are already captured in tools that are readily used. And this is also something which we then would circulate again to the participants of the Delphis, the patient advocates participating, and to discuss that and put that as part of the results section and the discussion section. And I think this is also something important that came up from those Delphi surveys, and I think that will be valuable information to the community. Okay, so with this, I think we are through. We also have a Menti on that one. I'm not sure why we have one for this one, because there wasn't a consensus. But if you are happy to do it I think we should move on. For this, we do not need one. Then we still have one Delphi that is open, where we would really love to have some additional participants. Everyone who thinks that the Delphis are a good thing and wants to contribute, please do that soon, because then we will have to close the Delphi, and then we can also close the last Delphi from Harmony, and then we would have fulfilled all the deliverables for the EU also. But as I had said, this is a starting point, and we will continue to refine the results of those within Harmony Plus. And now, how shall we do it in Harmony Plus? The problem was we had always these huge discussions, how to best set up the Delphi, but by the time then we started the Delphi, the problem was again that many people were not there who participated in the earlier discussion, and then for some of the new participants, it was not clear how to do it. And the plan is now that we think we do a save the date, where we have 2 dedicated time slots on 2 different days for a Delphi survey. We assume we can do it in 2.5 hours. We would invite all the participants, invite you to reserve those 2 time slots, which will be 2 or 3 weeks apart from each other. Let's say we do it on a Thursday afternoon or early evening, where everyone has time. Then on the first, and we call this Delphi Hackathon. We already heard hackathon, so that's a catchy word, and we hope that this also will attract people, and that concept is innovative enough to keep people on track, and that everyone is also participating in the same round. So the idea would be then on day 1, now after the meeting, we will again reach out to identify the participants, the stakeholder groups, and identify the people. You will get an invitation. We will do a doodle with a time, with the days that might be best for all of us, to identify a day where most of us can do the Delphi, and then we would block those two days, and it would more or less be a binding registration to commit your time for those 2 Delphi days. Then on day 1, we will give again a brief introduction, briefly mention the Delphi, explain the Delphi, how you should answer the Delphi, and then we would start the Delphi survey. And like it's a little bit like also when people are sitting in front of the Delphi on their own at home, then they start to go through the questions, and I think then they also start to think too much about each of the individual outcomes. And this is also not what a Delphi is meant to be. You should look at the variable, think, is this important or not? Do I understand it? Do I not understand it at all? But then rate quickly and not start to think about each variable, pros and cons, for 15 minutes. And this was also, I think, the problem why then many gave up after going through the first 30 variables. If you have a list of 80, it should be done quickly, similar to what Ellen was doing to us yesterday afternoon. You really quickly decide, yes, no, important to me, not important, more or less like your gut feeling. And with this, you can do a Delphi easily in 15 to 20 minutes. But nevertheless, if there is a part of the Delphi where you would have a question, where you do not know how to answer it, in that platform we would offer like breakout rooms where then Katharina, Renate, or I would be present. If you have a question, say for that domain, I do not understand that outcome at all, what does it mean? And I think this will be especially important for the patients participating, because they once in a while had problems with the lay explanations of the outcomes. So we could tell them what is meant, yeah, and then they can make their decision. And in that way, depending also if let's say Brian Huntley is a very well-trained hematologist, so he easily could, for example, then answer all the 4 Delphis on CML, MPN, Hodgkin lymphoma, and Waldenström. Those are the 4 new ones which we have to do in that first Delphi session. Of course, for many of us who are not so versed as Brian or patient advocates, then they only will have to do one of them, like CML or MPN. And then, of course, you do not have to reserve the entire time slot, but you only get the introduction and do your 1 Delphi, and then it will be only half an hour, 1 hour. And then, if we all do that in parallel on one day, the advantage is that we immediately afterwards can get the results, can do the analysis. Then that analysis will be distributed to all the participants. You can look at it at home. And then you are invited with the results for the second day of the Delphi. On that day, we will also again briefly present the results, because the idea is for the second day, you see what all the others from your stakeholder group and what the other stakeholder groups voted or what they thought is important. And then you have to go through the list again, rethink what your initial decision was, and then think whether you now would vote differently if you know the results of the others. So you can refine your voting. And then we do the same thing again. Again, here we would have the breakout rooms. If someone has a question, some understanding problems or whatever, we would be there to help, to guide. And then you again do so Brian would have to do then, of course, 4 Delphis again on that day, and the others 1 or 2, yeah. And then by day 2, we would then have the results, and the idea would be if we do it on 2 dedicated slots, that we do not have a dropout rate like we had for many of the other Delphis, which was in the range of 30 to 50% for some of the Delphis. And this will then also increase. And in that way, it's fixed time slots. And the other thing is also, the other good thing is then we can also fulfill the Delphi task in the time that we do not, and we can also stick to the deliverable time of 18 months, which we have to fulfill. So this was the idea, and I think we should give that idea a try. We will prepare everything. We will send the doodle, the invite, perhaps prior to Christmas or early next year. We already have generated these large lists on which we base the new Delphis. Those will be then also circulated to the respective KOLs prior to Christmas, that we get their input before we finalize the Delphis. And then we are ready to start, I think, in February. That would be the idea. February, I think, is a good month. There is not too many meetings. And then we hopefully can get results. And if this works well, then we would use that approach to refine then also the other Delphis to move on with additional goals and tasks we have to fulfill in Harmony Plus. And if that works well, I think just the concept itself is new, innovative, perhaps also can be published again within a trials paper, like the concept. And with this, I'm at the end, and I thank all the participants of the Delphis and my 3 colleagues, of whom 2 could be here today. Mathieu, unfortunately, was struck by COVID, and she had to stay at home, but she's fine. Thanks. And for the questions, I think we all can come forward. Thanks. If there is questions.
Yes, actually the questions are related a bit backwards, so I'm scrolling backwards as well. And I'm picking up the question again from MDS Alliance UK. And Ian Thomas. One moment. Ian Thomas says, I agree with Sophie's statement in AML where it is being demonstrated as important as presentation. It was how was physical functioning defined? Which? Sophie is now online.
Physical functioning?
It was a broad...
Yeah, Sophie is behind you, so she can also explain her specific question.
Yeah, Sophie, so that was... Yeah. Yeah, please go
Go
ahead.
ahead. Go ahead, Lars.
Oh no, yeah, physical functioning was like a broad category. There's many subcategories, but what we also agreed upon with the Delphi survey is that we should not start with a list of 150 variables, right? Therefore, some of the ones had to be put into like a broader category.
Yes.
So physical function, yeah, was not further sub-specified for that Delphi. Does that explain your question?
Yeah, but the fact that fatigue has been ruled out and it is very, very surprising to me, to our community, because it's definitely something that features very heavily in patient feedback, that fatigue is really one of the main issues. And Ian Thomas was saying the same thing for also AML patients. So it wouldn't be the first time that views of clinicians versus patient groups are a little bit at odds. It's been reported by various patient groups in the past. So I would really welcome an opportunity to explore this and how such a decision could end up.
Yeah, I'm definitely with you, but again, that the physicians for AML didn't rate it high enough in the light of the other variables does not by itself mean that the physicians think fatigue is not important, right? I mean, this is a little bit where the understanding, or yeah, that's a little hard to, yeah, how do I put it? Yeah.
Translate.
Yes, compared to the other variables, right? I mean, and we definitely can discuss that. I mean, that also would be a good part for the discussion of the manuscript. But I mean, this is how the results are, right? And perhaps fatigue in a disease that is one of the deadliest diseases, AML, in elderly patients. We just recently looked at the data. I mean, outcome is worse than for pancreatic cancer, especially in older patients. So in that light, we perhaps see very few survivors that really suffer from fatigue. So this perhaps is what then the physicians had in mind when they rated, right? I mean, this is just to explain.
I'm sorry, Lars. I'm talking more about the MDS. In
Oh.
AML, perhaps that was Ian's point for AML, but in MDS specifically, fatigue is really the most common issue.
We can bring in Ian.
Patients.
We can bring in Ian Thomas if you would like to react more, Ian, because you were chatting, Sophie and Ian. Yes, he is there.
But just to mention one, interestingly, interestingly, the patients voted the outcome as not important. It was only 56% of all patients voted the fatigue as critical importance. So it was not the physicians.
We definitely can share then detailed results with all of you. But I mean, today we only had a 1 hour slot, so we could not go through those in detail. But perhaps that would be good to have a follow-up discussion.
Ian is now behind you, so
hi Ian.
maybe you can address him first, and then.
Sorry, I think the point maybe that I was making about physical functioning was that it is a broad definition of an outcome, and it would be difficult to include that as a core outcome point unless you properly define it so that it can be attributed equally between trials. It's a very broad and ill-defined outcome, I would say, whereas fatigue is reasonably well measured.
That's a good point you're raising here. Is that, I mean, this is also still on our to-do list. First, we had decided to nail down what goes into the core, and then the next step is on how to measure what is in there in the core. And like you say, for physical function, that's harder to grasp. There we have also to work together and discuss how this could be best done. For fatigue, it's more easy. There is standardized tools. But also for let's say, MRD, which made it in the core outcomes. I mean, there the discussion is also open how to best measure it. But this is what we also still have to do within the prolongation or the extended period of Harmony and also Harmony Plus. Yeah, very good point.
You've done very important and great work, Lars.
Yeah.
So.
Hi. Hi, I have the microphone, but okay.
Yeah, maybe also focusing on acute myeloid leukemia, I think it also depends on the phase of the disease. So are you asking in the induction phase how the situation is of the patient, or are you asking after an allogeneic stem cell transplantation, or whether a patient is already 6 months in complete remission? That makes a huge difference. So I think that is also one of the reasons that it didn't make it.
Yeah.
And maybe I can ask another point. Do you also look to the how realistic it is to some outcome measurements? I refer now to, and I'll know that it is really an important one, but on to the compliance of the patients, and it's really difficult to measure that as an outcome parameter. So I forgot in which disease it was mentioned, but I think it's extremely difficult to report compliance.
Yeah, we had it. It was termed here medical adherence.
Yeah.
Yeah, I'm definitely with you. Yeah, especially, I mean, this will be important also then, I mean, in CLL, where patients survive forever and have to take, or CML, this is one of the diseases. I think there was very good studies done by, for example, Jane Apperly, who had an electronic device in the lid of the
CML.
tablets, where they, over Christmas, was never opened, and then prior to the next visit schedule in January, it was opened several times a day.
And holiday vacations.
Yeah, very good point. But this is also something where we, of course, can develop new ideas together with all the stakeholder groups.
Yeah.
Yeah.
Yeah, what I wanted to say is that fatigue can be a present symptom, but it can also be very difficult to evaluate in the future because it's mainly a qualitative variable. And to comparing these kind of results that can be analyzed and compared in big data analysis, it will be difficult to value this result, even if it's present or not, will not give actually a way to differentiate quantitative results that can be given by NGS results, objective results.
Yeah, this is another good reason, for example, why perhaps some of the physicians said, okay, it's hard to measure, and therefore I do not rank it important enough in AML, or whereas others also said, I mean, MDS obviously it was not the physicians who kicked it out, so that's good. Yeah, but that's definitely something we should discuss further in the future, and perhaps then we also need, I mean, with a hackathon concept, perhaps then also I hope that the participation will be larger and more consistent than because that, of course, also with all the shortcomings of the Delphi, we also have to keep that in mind and interpret the results cautiously. Yep, there's one more.
Yeah, thanks, Lars. Great work, and I think I like the idea of the hackathon very much. I think it's going to be much more efficient in terms of developing the core outcome sets going forward. I think the only thing I was surprised about from the ones that you have presented, I wonder if you have included quality of life actually as a pro. Because then because you have gone for individual domains that are usually included in quality of life measures, and I see also on the screen already people are putting HR qual validated measures and EQ5D as potential options. So I wasn't sure whether you have included it as a potential option or not at all in the pro.
They are shy. they are only here for 5 years. They have to get used to you.
No, we had a broad category of quality of life, so with a lot of subcategories and not. It was pro quality of life.
So the category we only wrote pro, but it was pro/quality of life. And many of the variables were in there. We can send again also, I mean also for the paper, it will contain again as a supplementary all the categories, all the Delphi's example, and on all the categories that were in there. But also what went into the Delphi was broadly discussed again with all the stakeholder groups, like all patient advocates from each of the diseases consented on the list of variables that goes into the Delphi. So this was not only our decision, this was also done on a broad basis. And with that we started, right? To now come at the end that we should have included another variable, we all agreed that those are the variables we look at, right?
I think that the problem is that usually with quality of life, I'm thinking from the clinical guideline development perspective and also from HTA perspective, it's usually mortality and quality of life, the critical outcomes. And usually quality of life would include most of these domains that you are listing separately. And we have been talking about quality of life being important to collect.
That's important. But I think for quality of life, we had agreed that category would be really too broad, that we include some subcategories instead, right? But then for the subcategory, let's say physical function, which is also of course part of quality of life. If your physical function is good, you are happier. And there we said we cannot go into even deeper subcategories, right? We had to find a compromise.
Yeah, which is like disease-specific measures, but the generic is also important. Yeah, thank you.
Lars, may I ask you to wrap up? I think people are in an urgent need for a break.
Okay.
And
one
we
more
also
final
have
question.
I have raised my hand for quite some time.
You have the final word.
I'm just announcing
because
to
I think
wrap up.
this is probably a central point. These conflicting results in fatal HMs. And the question that arises is how representative are the patients in diseases with a high fatality rate? Because those patients who are rating are the survivors. And the 80% who died, who are in the minds of their physicians, of course, they are not around anymore.
Yep.
And I think this has to be considered also by the patients, how representative they feel in a given disease.
It's a good point, right? But it's not conflicting results in a way. It's again, that the others didn't make it doesn't by any sense mean they are not important, right? We had to narrow down all the 80 variables that went into the game are important, right? But we had to nail it down somehow to 15, and those are the 15 who made the game. And like you said, if we would now vote today, we would get another result than with election we had in September in Germany, right? Things change. But the results from the election in this September is what it is, and this is what we are now seeing here, and it's a starting point based on which we can move forward. Okay, now we have time for a small bio break. Thanks again, everybody, and
5 minutes.
We'll be back in 5 minutes.
Thank you very much.